overall, I got the title of talking about the effect of PMF fiber on triglyceride. So I just stole this one slide from the speaker will have just right after me, but just trying to show that in these patients where they had triglycerides of 150 to 500 milligram per deciliter, and as we in France, 1.7 to 5.7 millimoles per liter, what was the effect of PMF fiber? And certainly here, compared to fenofibrate, 107 milligrams to 2 doses of PMF fiber, it was a reduction of 46% in triglycerides, and also some increases in HDL. But of course, I will focus on the low triglycerides. So I won't go into all the other trials because we'll hear about that in the next couple of talks. But more, what would that potentially mean? I work in a big clinical lab. This is when you have plasma, and there's actually 3 different types of plasma you can look at. That's when it is clear, you can have high LDL or maybe high Lp(a), high cardiovascular risk if it's high. But then what we're talking about here is the one with turbid plasma where triglycerides and remnants are high. And in my way, the way I read the literature, they probably actually have even higher risk of cardiovascular disease than the one that only have high LDL. And then, of course, the special case with chylomicronemia, we're not talking about that here. 4 different major lipoprotein classes in plasma: HDL, LDL, remnants, and Lp(a). In clinical practice, we measure cholesterol here, and HDL, cholesterol, and LDL, and then we have been used to measure triglycerides. And I think, or we measure triglycerides, and then clinicians talk about triglycerides. And I think that's part of a lot of the confusion about triglycerides, because in my mind, it is more likely the cholesterol content in these particles that end up in the arterial wall and cause atherosclerosis. Triglycerides might be important also, but it's not triglycerides per se. So that's why I've always worked on calculated remnant cholesterol, which can now also be measured directly. There's an assay from Denka in Japan. Some people prefer to call it triglyceride-rich lipoprotein cholesterol. And then, of course, there's Lp(a), its total mass. When people talk about non-HDL cholesterol, I know many people do it. Also, among all of you very smart people, are very learned. And of course, I'm very humbled to speak to all of you because I know you, each of you, have your own view of the world and how lipids are and so forth. So I can only say mine, and my hope is just to influence just a few of you a little bit. For example, Phil Barter, but I know that's a hard one, Phil. Yeah, but I'll try anyway. So many people like to talk about non-HDL cholesterol, but that is a composite of LDL, remnants, and Lp(a). The same when you talk about ApoB. So these might be fine in epidemiology, but I think they have very different things. These 3 lipoproteins might be very different for how they cause disease. So sometimes it's better to talk of them each by oneself. Here's just, in this paper we published this year in Nature Reviews Cardiology together with Steve Nichols and Langsted Ray and Tyberg Hansen. In the Copenhagen General Population Study, we tried to head-to-head compare LDL cholesterol, remnant cholesterol, and Lp(a) cholesterol. So we did the cholesterol to put them on the same scale. So it's a 1 millimole per liter increase of 39 milligram per deciliter. And when you look at the observational association, here's for LDL cholesterol, but remnant cholesterol actually give a higher risk estimate for the same increase in remnant cholesterol, and Lp(a) even higher, maybe because it's not only cholesterol and Lp(a), but something else. And when you look at the genetic estimates shown here, they all show that these are causally related, and they are adjusted for each other, so they are completely independent. So each of these have an additional causal relationship with cardiovascular disease. In this case, we looked at myocardial infarction. I think this is some new data. It's unpublished, or it's in press. It's coming out maybe in a week time in clinical chemistry, I hope. Just to try to illustrate how I think about it, what I think is very important. So this is in these 2 Copenhagen studies with 116,000 individuals. What's the relationship between plasma triglycerides and millimoles per liter? So 2 is 176 milligram per deciliter. And plasma C-reactive protein on normal people living in the population, just like you guys. If we measured it in you probably all eat healthy. Nobody took dessert up here, right? Nobody took dessert. I noticed, yeah. Maybe only me anyway. So then what you can see as triglycerides go up, CRPs goes up all the way up to 5 millimoles, which is almost close to 500 milligram per liter. There's a very nice relationship. So this is a curve that fitted all the data. And so when you come up here, there's not so many people, so the estimate becomes imprecise. And I should notice for you, I think some of you have perceptions that LDL cause inflammation. But here, in exactly the same people, with exactly the same statistical methods, this is the relationship between increasing LDL cholesterol and CRP in the population at large. And I don't see as LDL goes up, CRPs go up. It's when triglyceride goes up. This one is a composite of two previous papers from our group, one from Annette Warburg and Langsted, and we compiled it in a review. So here is comparing observational with genetic for when lipoprotein(a) increases 50 milligram, LDL increases, or remnant cholesterol here. This is a bit smaller, but anyway, the observational association, how much does CRP change? Well, CRP goes up a lot. As Lp(a) go up, it goes up much less when LDL goes up, and it goes up a lot when remnant cholesterol or triglycerides go up. But when you look at the genetic estimates, there's nothing for Lp(a), there's nothing for LDL, but genetically lifelong high remnant cholesterol, high triglycerides is causally related with more CRP. So I just want to bring in Paul Ritger's trial here, and I know both Peter Libby and probably Aruna, she's probably also involved in the trials, and many other ones in this room, but I think this helps me understand something about what could this inflammation part of high triglycerides be. So the CANTOS trial, of course, different doses of canakinumab versus placebo, and what was beautiful about the design of this trial, of course, was that when we here look at what's the high sensitive CRP as a function of month of follow-up, the placebo went down a little bit, but the three groups of canakinumab, particularly 150 milligram and 300 milligrams given subcutaneous every 3 months, made it go down a lot compared to placebo, and then no effect on LDL, no effect on HDL, and hardly any effect on triglycerides, maybe a small increase. And that translated, as we all know, into here MACE or MACE plus for the placebo and for the canakinumab that had 35 to 40% reduction in high sensitive CRP and IL-6 in reduced risk, 15% reduced risk. So when you don't change the lipids, but just try to dampen the inflammation, 15% less MACE events. I think that could be important for interpreting how triglycerides could work. And then, of course, this new one here also in the front row being involved in a trial together with Paul Ritger, presented just American Heart Association this November and published online in New England Journal of Medicine, the CERT trial with methotrexate low dose versus placebo, and there was absolutely no effect or no influence. The hazard ratio was 1.01. And then, of course, from Paul Ritger's presentation in the American Heart Association comparing the CANTOS trial with the CERT trial, that here, the CANTOS, it was reduction in IL-1 beta, IL-1/6, high sensitive CRP, and then a 17% reduction in MACE plus. Whereas the low methotrexate trial, there was no changes in these inflammatory markers, and there was no change in MACE or MACE plus. So back to the triglycerides. Here, Annette Warburg, I did this paper together with. Here is in plasma, and here's in intima. We know that these three large lipoproteins, I took out HDL and Lp(a), but the chylomicrons, as Marcio already said about, they are too large to come into the arterial wall, and also particularly, I think, if you have homozygosity for lipoprotein lipase, loss of function, nothing will be degraded of triglycerides, so they can't even produce inflammation. It's just inert big fat in plasma. Anyway, when they are changed into remnants or whatever you like, remnant cholesterol, VLDL or IDL, then they can come into the arterial wall just like LDL. So they can come in, but the large remnant seems to be stuck more in the arterial wall compared to LDL because there's a constant blood flow coming in this way, so it's very difficult to come out again. The remnants can, through lipoprotein lipase degradation of triglycerides, either at the surface of the endothelial cells or within the intima, liberate free fatty acid and monoacylglycerol, and these are very toxic to tissue. So they will lead to local inflammation. Also, remnant or triglyceride-rich lipoproteins can immediately be taken up by macrophages to produce foam cells, which of course contain all the cholesterol. Why is this important? I think so because for LDL, we all learned about this. LDL needs some sort of modification before it can be taken up by monocytes. That's why there was all this thing of acetylation and oxidation and aggregation. That's not necessary for remnants. You just give it to a macrophage and it'll take it up and eat it immediately. Here's a different way of looking at it. It seems to me that when you have remnants or triglyceride lipoproteins, there's these two major fats in these particles that can be important for atherosclerosis. There's the cholesterol content in yellow, taken up by macrophages, foam cells, and the cholesterol will stay here because they cannot degrade cholesterol, and you will have cholesterol in the atherosclerotic plaque. This is why I talk about cholesterol or remnant cholesterol in the triglyceride lipoproteins, because in the end of the day, it is cholesterol that is deposited here. It's not triglycerides, it's not ApoC3, it's not ApoB, it's cholesterol. So that, of course, as we all know, is very important for myocardial infarction and other atherosclerotic cardiovascular disease. However, for these particles, the triglyceride component may also have an important part, namely because lipoprotein lipase, as I said before, will degrade into free fatty acids that are toxic to tissue, generating local inflammation, maybe not only in the arterial wall, maybe in many places in the body, in adipose tissue, in muscle. Where do I know where there's free fatty acids? And that, we know, leads to acute pancreatitis at some patients, but also I think this inflammation generated by free fatty acid, maybe locally in the arterial intima, could be what makes an atherosclerotic plaque rupture and then cause the final event, the myocardial infarction. So here in my simplified way of looking at the different lipoproteins, HDL, I don't think we want to talk too much about that today, but the three other here, LDL remnants and Lp(a), how I see it when I try to make the totality of evidence, I think LDL, of course, is very, very important for causing atherosclerosis, but maybe more stable plaques. Maybe we know that for homozygous F8s or even heterozygous F8s that they get a lot of atherosclerosis, but it takes a long time before they get the plaque. While if you have triglyceride-rich remnants, they may be the ones that are maybe particularly important for having unstable plaques that can lead to rupture because there's more local inflammation. And then Lp(a), how I see it, may be more important. Once you have a plaque that ruptures, maybe Lp(a), while you have a thrombosis, will indirectly make this grow faster because it inhibits fibrinolysis. It's nice, right, Phil? I can just stand up here and say whatever I want without you can saying the opposite to me, but you'll be allowed afterwards, I'm sure. Anyway, so here's how I see of the triglyceride lipoprotein. Of course, there's the non-fasting states when you have chylomicrons, you eat fat, and lipoprotein lipase will degrade some of it. You have chylomicron remnants, and then in the fasting, VLDL from the liver, lipoprotein lipase, IDL, and LDL delivering cholesterol to the peripheral tissue. And then what we call remnant cholesterol is just the cholesterol in all these particles together. So it's all the cholesterol that is not in HDL and not in LDL, just all the cholesterol in triglyceride-rich lipoproteins. And I think one important part is because when you particularly look at the non-fasting stage, so here this is time since the last meal, then between 2 and 5 hours after the last meal, you have a little bit higher remnant cholesterol, a little bit higher triglycerides. So there you might be even better at capturing people with high risk of these lipoproteins. And even the American guidelines now, finally, ACCHA at American Heart Association said it's fine to use non-fasting. Let's use that. Why do I talk about remnant cholesterol? Well, this is now probably too simple for you people. You're very smart people. But anyway, I just want to say how I think, because I think you can communicate very complex with many details, and I think often things become very unclear. And this is like when there's a new law in society, you can go and read the law. I don't know if you guys do. I don't. I had a few in medical school. I had to read these laws. I thought they were pretty complicated, but maybe some of you people do it. But so I like this here. When it's simple, there's no detail, and it's completely clear. So if I'm on a good day, I'll probably read the New York Times, but that will be a whole page of these new laws, all sorts of details and pro and cons and things. And if that's too much for you, you can, when you sort of like, if you get to sort of like lunch and you had a beer, you can just take a tabloid, and then on the front page, they'll actually tell you the bottom line. And then if even that's too much for you, you can just watch TV, and they'll have a few sentences, and they will interview one that's against and one that's for. And even if that's too much, then while you drive your car, you can just listen to the news. 1 or 2 sentences, that's completely clear. So what about if you want to talk about triglyceride-rich lipoproteins? How can you communicate? Well, you can, we can do this here. You can do with metabolomic phenotyping and all these different fractions, and you can, then one is a little bit higher than the other one, and this is so fantastic. I mean, it entertains a lot of scientists to do it, but what I usually do, I just look at my lab and see if plasma looks like this, then I know they have high remnants. It's not complicated. And then there's different degrees of complications in between. You can do a full ultracentrifugation. I did a lot of that in my early days as a scientist, and then you can or a full lipid profiles, but you can also just calculate remnant cholesterol. That's easy. It's just total cholesterol minus LDL cholesterol minus HDL cholesterol. That's all, and there's a direct assay now. That's very simple, but of course you have to believe that it's the cholesterol in the triglyceride proteins that are important. So, just some background epidemiology here from the Copenhagen studies. As triglycerides go up here in millimole per liter and milligram per deciliter, there's the hazard ratio for myocardial infarction among 96,000 individuals, 3,300 myocardial infarction events. And at triglycerides close to 7 millimoles per liter, it's 5-fold risk compared to if it is less than 88 milligram per deciliter. So that's actually a lot. It's one measurement, non-fasting triglyceride. We follow people for up to 40 years. And that's what it looks like. And then the same study, now it's just ischemic stroke. There's 3,000 ischemic strokes. And again, the same studies, because in Denmark we have these fantastic registers for all-cause mortality. Every single person is tracked. Here's all-cause mortality. When triglycerides is above between 6 and 7 millimoles on average, there's a 2.5-fold risk of dying early on compared to if triglycerides is less than 1 millimole or 88 milligram per deciliter. Just on Marsu's talk, just to remind you all that the most important factor for having high remnant cholesterol and high triglycerides is how much you eat and how fat you are. So here's in 106,000 people from Copenhagen, body mass index deciles. The reds are the ones that are usually called obese. These are the ones that are called overweight, and these are the ones in the normal weight range. And it certainly looks to me like as you get more body fat, you have more remnant cholesterol, more triglycerides. And the R square is actually 12, which is rather a lot for such a lifestyle factor. But this is in the general population. What about in trials that have had statins? And there's a lot of trials like that. Here, I just take one of them here, just published this year in Circulation by Vallejo Vaz in Cosray, was the senior author in the TNT trial. And then they're sort of like a little bit scary about the word remnant cholesterol. So they call it triglyceride-rich lipoprotein cholesterol. But it is exactly the same. They calculate exactly the same. They're just afraid of getting some of you guys as reviewers and then you say, oh, you can't use this expression. It should be triglyceride-rich lipoprotein cholesterol, but I think it's more complicated to say. Anyway, so in this trial, this was the group that received 10 milligram atorvastatin, the 5 quintiles of higher and higher triglyceride-rich lipoprotein cholesterol. The highest group had the ones that the highest risk of major cardiovascular events as remnant cholesterol got up, even though they got a statin, higher risk. And here's when they looked at who got the treatment benefit in the TNT trial. So this is now comparing atorvastatin 80 milligram versus 10 milligram. Who got the benefit? So if it is better to have atorvastatin 80 milligram, this was the 3 groups with the highest remnant cholesterol. The ones with the lowest remnant cholesterol didn't get any treatment benefit. And here's a lot of the other trials. I probably missed some of them, but you can see all these studies with a lot of famous people, probably a lot of you are co-authors on some of the papers, they essentially say all the same. So these studies all say that triglyceride-rich remnant explain cardiovascular mortality residual risk beyond statin therapy, and it is independent of LDL cholesterol and HDL cholesterol changes. It's just reduction in triglyceride-rich lipoproteins. I never accepted the thing that people said that statin trials didn't work. They worked fine. It's just some of the statin trials, like these here. Fibrates trials. Some of these trials, they only reduced triglycerides very little because they recruited people that didn't have high triglycerides. But some of the trials over here, they recruited people with high triglycerides. So here, this is a meta-regression looking at what's the reduction in triglycerides in millimoles per liter and what does that mean for an odds ratio of cardiovascular disease. And it seems like overall, a 54% reduction in major cardiovascular disease events per 1 millimole triglyceride reduction. And of course, there's all these fantastic new trials. There's the REDUCE trial I just show shortly about the results here. So they are all triglyceride-lowering therapy to reduce residual MACE after statin therapy. So the EPA, it has just been presented. I'll give you a short brief of the results. And then the STRENGTH trial, EPA and DHA, 13,000 individuals fully recruited. And then, as Aruna will tell us about a bit later, the PROMINENT trial with the drug we're talking about here today, more than 50% recruited by now. So the REDUCE trial presented at AHA and just online in American Heart or at New England Journal of Medicine, inclusion criteria age above or equal to 45 years with established cardiovascular disease, so-called secondary prevention cohort, or greater than or equal to 15 years with diabetes and more than or equal to one additional risk factor for cardiovascular disease, the so-called primary prevention cohort. They should have fasting high triglycerides, meaning more than 150 milligram per deciliter and less than 500. And then they should have LDL relatively low on stable statin plus or minus ezetimibe for at least 4 weeks prior to. So it's a trial that recruits people with high triglycerides, and then they give them a drug aimed at reducing triglycerides. So we can later come into all sorts of speculation about how do we interpret the results, but it's a trial where they recruit people with high triglycerides and then they give a drug to reduce triglycerides. So maybe we should think of the effect being there. So here's the primary endpoint. It's MACE again, cardiovascular death, MI stroke, coronary revasc, unstable angina. And here's the placebo group, and here's the APA group with the total events of 28%. First of all, I think it's worth noting that after 5 years, 1 in 3 in the placebo group in this group actually had a new event. So that's a very high baseline rate, much higher than in some of the other trials where we try to reduce LDL further upon statins. The hazard ratio was 0.75, and there was 8,000 individuals in the trial. And the conclusion of the trials compared to placebo, EPA, 4 grams per day, significantly reduced important cardiovascular events by 25%, including 25% reduction in death due to cardiovascular causes, 31% reduction in heart attack, 28% reduction in stroke. There was a low rate of adverse events, including a small but significant increase in atrial fibrillation flutter. We don't really know why. And then a non-statistically significant increase in serious bleeding, which you could think about giving it an omega-3 fatty acids. And then there was consistency, efficacy across multiple subgroups, including baseline triglycerides from 135 to 500 milligram per deciliter, including secondary and primary prevention cohorts. And then, how can that be? Of course, I mean, now these people did all this work and the company paid for it, and then the rest of us could spend many years to try to interpret it and write papers about that. So that's what we're here for, and I'm sure each of you will have your own interpretation of it. So I just tell something what I think. So this was presented at the AHA. This is the different biomarkers, baseline and year 1, and here's the difference between the two groups. And one thing that certainly one can look at, what's the difference in triglycerides? 20% reduction in triglycerides. Non-HDL went down and LDL also. And of course, that's the special issue we already alluded to, that in the placebo group, LDL actually went up, maybe because of what they used as a placebo. And then CRP went down a lot, 40% on a continuous scale, but on a log scale, 23%. So it's actually very similar to the triglyceride reduction on a log scale. And then I'll come back to like the study I showed from our own paper that's in press. When you look at, can this some way be explained? That so here, the median triglycerides in REDUCE-IT was up here, and then they reduced triglycerides and CRP about 20%. So certainly this could be just part of it. Because you bring down triglycerides, you have less free fatty acids, you have less inflammation. And then another thing I think that will be discussed a lot and is being discussed a lot is this subgroup analysis, that even the one with triglycerides less than 150 versus the one with more than 150, they had similar effect size of beneficial effect with reduced MACE. And then people say, oh, how can this be? This is just normal triglycerides. But I have to remind you, when we started with reducing LDL trials, people thought that LDL was normal when it was above 5 millimoles. And then as years went by, we realized normal LDL is much lower. And I think that's exactly the same that will happen with triglycerides. So here I just show you from the Copenhagen general population study in men and women, the distribution again. And as you can see, what we use as a reference is less than 1 millimole. There's actually 45% here from 1 to 2, and then there's 38% up here. And here's the values for women. So there's a lot with very high levels. But then what's biologically normal? And then I have this graph here from the Copenhagen general population study looking at as a function of age. So when we measure on newborns, the triglycerides level is less than half a millimole. That means it's down to maybe 30 milligram per deciliter, and that's usually what we see in most animals when we measure triglycerides. So that's probably what is biologically normal. In children or adolescents, they have about 1 millimolar, 88 milligram per liter, and then in men increases a lot, and then women only later. Maybe in Denmark, the men drink a lot of alcohol. That's maybe part of it. So I think this is my final slide. I think when you say, or when people think that even when you have very high triglycerides, relatively low triglycerides, and reduce it with EPA, you get a beneficial effect, but 150 milligram per deciliter, that's like this group. So it's like coming from here to here, and there's still a change in hazard ratio from 2 to 1. So there's plenty to do even down there when you reduce triglycerides further. So I think for me, that's the most likely interpretation of the REDUCE trial. It's you recruit people with high triglycerides, you give them a drug that reduces triglycerides and thereby reduce inflammation, and then you have a very beneficial effect. So the most likely explanation is that that's the reason for why you see the less effect. But I'm sure there's many, many, many other people that will speculate about, membranes, platelets, and all sorts of things. And that's fine. That'll keep us busy for years to come. Thank you very much for your attention.